And we know that in the spinal cord, not only in the CNS, in the spinal cord, these two chemicals are involved in pain perception pathways, especially ascending pain pathways. And so depletion of them actually lowers your pain threshold and increases the perception of pain. So again, an SNRI, not just an SSRI, would be important here. And we know Cymbalta, which is duloxetine, is actually FDA approved for painful symptoms. Tricyclic antidepressants, and then alpha-2 delta ligand, which has to do with GABA, and has to do with regulation of norepinephrine and dopamine. That's in serotonin, sorry. And so pregabalin and gabapentin, we know, for instance, that pregabalin has been FDA approved for fibromyalgia, for instance. Depressed mood, we know, disrupts brain deactivation and enhances pain unpleasantness. So we know, again, there's central mechanisms, and there's also in the spinal cord. And so what you can see is this is a study of 12 healthy volunteers. Green is activation versus rest. Blue is deactivation versus rest. And there's a significant lack of the deactivation during pain in the depressed mood state. So you can see here, if you look under pain at the top, patients who have mood, normal mood, if you will, on the top versus depressed, and you'll see the depressed patients have a very significant difference in their activation and deactivation cycles here. They're not deactivating when they should. In other words, they're not turning off the pain pathways, so they keep registering pain. Patients reporting the greatest increase in pain have more unpleasantness after sad mood, and induction showed greater induction in certain areas of the brain, the inferior frontal drivers and the amygdala activation. Now, amygdala is the anxiety and fear center, and so there may be something involved, and it's very heavily innervated by serotonin and norepinephrine. So that may also be involved with pain and anxiety. The role of norepinephrine here, as I mentioned, has to do with not only in the CNS, but in the spinal cord and the ascending pain pathways, which you see here. And very often, patients with depression, they actually can present to their primary care doctor with complaints of back pain, stomach pain, muscle and joint pain, overall fatigue, achiness. And that's what's going on here. We know that things like muscle joint movement, so if your muscles are tight, a lot of the time, if you're stressed or anxious, you know how we tense our muscles, you may not even be aware of that. And so that can cause chronic pain activation as well. Serotonin, you can see here, also involved, and serotonin is especially involved with the gut and digestive pathways. So that can be where that comes from. And SNRI action boosts norepinephrine inhibition of pain, as well as serotonin inhibition. And so you see what's happening here. You boost norepinephrine, and now you're deactivating these pathways and regulating. And same with serotonin here. And here we have descending pathways as well. So that you now regulate descending pathways, which helps with gut function and pain. Okay, so there's a lot of evidence, as I mentioned now, and in particular, duloxetine is actually FDA approved for these indications. 60 milligrams once a day. Higher doses increase side effects without necessarily increasing the pain efficacy. You may need to go higher for antidepressant effect. Milnacipran, which is an SNRI, and these drugs do differ in the ratio of serotonin versus norepinephrine that they're affecting. As I mentioned, venlafaxine tends to be mostly an SSRI at lower doses, so to get this effect, you would probably want to push higher to get more norepinephrine involved. And desvenlafaxine as well, which in my experience, about 50% of patients, this is Christine, 50% do well on 50 milligrams, and about half of them you need to go to 100. That's just roughly my experience. And then tricyclic antidepressants, we know amitriptyline, for instance, has a long history of being used for pain. And actually, sometimes lower doses that are lower than an antidepressant dose can help with pain. So it's not just helping with sleep when they give it at night, pain specialists. Now, you can also, excessive nociceptive activity can also be involved in the pain pathway. And so there's a mechanism here, alpha-2 delta ligand. So these are drugs that work again through GABA, which is the major inhibitory neurotransmitter. So you're trying to now help GABA decrease the painful sensation, inhibiting some of this chronic input here that causes neuropathic pain. And they include pregabalin, which is actually FDA approved, as I mentioned, for these things, and here's how you dose it. Gabapentin has been approved for postherpetic neuralgia in particular.